Sure. Let me introduce myself. I'm a professor in the Department of Supply Chain Management at Arizona State University, and happy to be doing this. I've been teaching supply chain management for several decades, and teach in our MBA program and our undergraduate programs in supply chain. And our focus has been on healthcare, principally in the United States, but I've also done work in the Middle East. We designed the supply chain for King Faisal Hospital in Saudi Arabia. We've worked in Kazakhstan, Uzbekistan, former Soviet Union countries, as well as Europe. And so some of the data I have will be perhaps a little focused on US, because I don't have the same kinds of data always for Egypt, but please stop and ask questions when you do. Maybe a few of the students could introduce themselves and tell me why they are interested. That would be nice too.
Okay, thanks, sir. First of all, good evening, everyone. I would like to welcome all of you to the first seminar in the second year of ISCEA Student Chapter Egypt. My name is Omar Hagras, President of the Student Chapter. We all know that the healthcare supply chain is a very important topic. So today we are going to talk about supply chain for hospital and hospital system as degree of integration between organization, internal and external supply chain members to manage the inter and intra-organization process. With our expert for today, Prof. Schneller, he will be going to understand for us about more details in this topic. So I think that maybe our colleague in the board maybe introduce themselves, or other colleagues that want to introduce themselves.
Yeah, give me 1 second. I need to shut Alexa off. She's in the background and talking to me, and that's always bad. Alexa, shut up. Thank you. The music is nice, but you didn't need the background. So maybe a few of you could introduce yourselves, tell me what you're interested in and your programs, and then we can move forward.
Yeah, I think that our students are studying supply chain, and there is some students studying transportation, some of them studying healthcare supply chain. So all of them has a background about supply chain. Maybe some of them know more about healthcare supply chain. Some of them maybe know and general lines in healthcare supply chain. So in general, all of them know the concept of supply chain, transportation, healthcare supply chain in general. Some of them go in details inside it. Some doesn't go in details. So I think that they want to know more about healthcare supply chain, specific in hospital and hospital system, as we going to talk today. That maybe things that it's our background for them.
Okay, can you see the slides now?
Now I can see you only, not the slides.
Okay, let's see if we can get the slides back on here.
Okay.
Oh, here we go.
Okay, now we can see it.
You can see them?
Yeah, now it's clear.
Okay, let me see if this is better. Okay, is that okay?
Yeah, it's okay.
Very good. Okay. So today we're going to talk about supply chain. Since many of you have already studied it, I won't spend much time on definitions. But when we think about healthcare supply chain, we tend to think of all of the activities from sourcing products and procurement and all of the logistics of getting products to where they are, including the coordination and what that looks like. So I will talk about many of those issues and then some of the factors that I think are unique to healthcare supply chains, which may be of some interest to you. As you can see in this slide, supply chains are about different flows of information, product, funds. Probably what's not on here, I should also add, is the supply chain for human resources, doctors, nurses. They're also part of a supply chain that comes out of medical schools, nursing schools, others, to be able to do that. Are you seeing the slide that says supply chains are all about flows?
Yes.
Yeah.
Okay, good. So supply chains are everywhere. They're in all industries. In healthcare, they're interesting because a hospital uses medical devices, as you know. During COVID, we saw that the supply chain had major interruptions, and I'll talk about that in some detail. But it's also not just about those medical pieces, but it's also about if you go into a hospital, hospitals have cafeterias, they have food. So they're part of other supply chains than the biomedical supply chain. They tend to interface with all. Hospitals have many computers, and those computers need repair. They need all the things that happen. So that's really important. I'm going to focus mostly today on downstream. That is from the supplier to the hospital and not upstream in terms of manufacturing for supply things. Interestingly, a hospital has a large number of products. Those products are sometimes as many as 50,000 products within a hospital's item master or its charge master. And many of those may be very focused on patient care, but others on other aspects of the hospital. One of the things that makes, now you're seeing the slide now that says among other industries, is that clear? Yes?
Yeah, it's clear.
Yes,
Good.
clear.
Okay, I'm just checking. I'm seeing several different screens. So hospitals are unique in that they tend to do some direct purchasing from manufacturers, but many of them use group purchasing organizations. And that is a group purchasing organization is many hospitals in a country or within a community coming together to purchase collaboratively. And what they achieve by purchasing collaboratively is the ability to have leverage with suppliers to be able to purchase at better prices. And so that's very important. And one of the things that's really unique in the healthcare industry is the presence of clinicians. And here I refer to both doctors and nurses. And those people tend to have very strong preferences about products. So physician A may like a hip from Stryker, another physician may like one from another manufacturer such as Johnson & Johnson. And one of the problems that a hospital has in its supply chain is getting clinicians to agree on what supplies to use, because obviously you want to be able to reduce your supply base. And in reducing that supply base, you have more leverage with suppliers for negotiating. But also, if you have many different products that accomplish the same thing, you have risks of the nurses and others who are helping to prepare surgeries utilizing the wrong products or utilizing the wrong instrumentation. So standardization is a very important area, and it's much more difficult because of what we talk about, and I'll go into some more depth of physician preference. And that's sort of a very important aspect of this that we we need to think about as we talk about healthcare supply chain. Okay. The next slide, what you can see here is the ecosystem of healthcare. And so we have clinicians, manufacturers, distributors, and sometimes we tend to forget about the patients because obviously at the end of that supply chain, there is a patient who needs a product or a product that a physician needs who acts as a surrogate in terms of using that product to do that. And so within this configuration, we need to take into account physician preference, as I've said, but also patient safety, the technology assessment, and all of the financial issues that go into purchasing what those supplies are. And that's important. So here and by the way, you can have these slides, you can distribute them. Here you have a schematic of the healthcare supply chain and the various issues that really are within it. And I'm not going to read them all to you, but a lot of it has to do with the reliability of the supplier and the decisions that you have to make, whether you make the decision to single source, which really opens you up to kinds of disruptions that might happen in the supply chain, or if you dual source or multi-source. And for single sourcing, obviously you may get leverage with a supplier because you're going to buy a lot, but you're also vulnerable to what happens in terms of that supplier and their supplies, and that's important. The second thing there is predicting demand. And in general, hospitals have difficulty in predicting demand. Just think of what happened in the disruptions during COVID, when demand for personal protective equipment went up substantially. And we didn't know when that demand would end, when that curve would begin to go down. And now as hospitals and healthcare systems, both government as well as hospitals, think about resilience, they're talking about having backup. But how much backup can you have? How much can you afford? What's the cost of managing that to become more resilient? And resilience does come at a price, and we can talk about that in more depth as we go forward. Okay. Then, of course, we need to take the time to study supply chain in healthcare because the expectations are very, very high for the supply chain. When a doctor reaches in a drawer and the instrument's not there, that doctor sees that as a failure of the supply chain system. They don't pay much attention to the supply chain every day when things go well, but by and large, the healthcare supply chain becomes most noticeable when things don't go well. And we have to think of the global environment in which supplies are there. So over the last years, there have been amazingly high levels of outsourcing, manufacturing, and parts of that manufacturing to parts of Asia, to India, et cetera. And what we had during COVID was a disruption of that. And so one of the things to achieve lower costs, and we always think of healthcare supply chain as cost, quality, and outcomes, and cost is very important. But if you outsource so much of that to reduce costs, and then there's a disruption, then you have problems, and you may not have the quality in terms of what you have. So one of the things that a supply chain executive in healthcare has to do, and by the way, that's not unique to healthcare, they have to be able to look at sourcing both globally, locally, as well as in terms of what is happening. So that's very, very important to them. Why is healthcare so costly? Healthcare supply costs are growing about 50% of other expense categories. So if you look at the charts here, what you see is the non-labor costs. In a hospital, as I'll show you in a minute, a supply chain cost can be as much as 30% of the total spend. They are the second highest spend to a hospital after human resources. And those the revenues are very, very expensive. And that's really important to understand in terms of the total expenditure. Here we have a growth in non-labor costs, and for supply chain, we have close to 10% that's happening year after year. And it's interesting, if you look at contracts within the healthcare supply chain, frequently those contract pricing doesn't go down every year. The pricing seems to go up every year, which is important. In the US, if you think of a large hospital here an $800 million hospital system has about $200 million of supply expense. So that's pretty significant. And therefore, if you can get savings in that through better sourcing, through inventory reduction, through standardization, contract compliance, and product flow, you're going to have better outcomes in terms of your financial outcomes, but also in terms of managing those inventory flows and their sourcing. One needs to be consistently thinking about the resilience of the system and not do that to such an extent that you expose the system to greater risks. And that's very important to think about. Just to give you a breakdown, supply chain expenses consume, as I said, as much as 25%. And I know areas in some hospitals where it's as much as 30%. And by the way, all hospitals aren't the same. Some of them do very expensive surgeries, and very expensive surgeries are things like hip repairs. They're putting in new knees into people. They're doing open heart surgery. Those hospitals have what I would talk about as supply intensive admissions of patients that utilize lots of supplies. Spine surgery and cardiology are the two largest ones where you see that, okay? But other hospitals don't do as much surgery on patients who have high levels of acuity. And therefore, when you begin to look at hospital expenditures and you want to understand that within supply chain, looking at the hospital acuity is very important. And this just sort of breaks this out a little bit. It shows you the direct labor expense. And then you see the hospital supplies broken out. And what's interesting in this chart is that 61% of those capital expenses are for physician preference items. So as I've been suggesting, healthcare is unique in that it has professionals who do those things, and that's very important to recognize. The goals for supply chain management, if you think, and again, I looked for similar data for Egypt and some other Middle Eastern countries and just couldn't find it in the same way. But what you see is that in the US, a well-managed company, not in the healthcare industry, will generally have a decline. If you think of Honda America, which manufactures cars here in the United States, their supply chain management expects to have much lower costs. But when you look at healthcare, product price index, it goes up, but in healthcare, it goes up consistently. And that's an important kind of feature to understand. So this chart, supply expense by type of hospital, and you might want to, for an assignment, go look at some different hospitals within your own environment. You know, a general medical surgical hospital will maybe have a 15% supply chain expense, but an orthopedic hospital might have a 34%. Because they use lots of implants, they use many resources that are there that are important. So the kind of expense one sees of supply chain in healthcare tends to depend on the kind of organization you're thinking of. So what is a high performance supply chain management? It's one that really looks at expense savings, balance sheet improvement, and just think every time you have a saving in the healthcare supply chain, it drops to the bottom line of the organization. It increases their profitability, which is very important. If you're in a for-profit system, which we see in many countries, that means you have more money for your investors. If you're in a not-for-profit system or a government system, that's the ability to provide more care to patients. And that's really important. And all of this should, of course, should take place within the context of thinking about the quality of products that are there for patient care. So some defining features of healthcare supply chains that I've been talking about are, one, the overarching goal is to improve and even save lives. And therefore, you can't afford to have stockouts. You can't afford not to have anesthesia for patients. And therefore, you need to think about the reliability of your supply chain. When we were working in Saudi, the time generally between a purchasing order and something to arrive, unless you did it by air freight, was approximately 2 months. And so you have to be able to think, given where you are, what country you're in, and what kinds of stores and distributors are there, what it takes for them to be able to replenish what their supplies look at. And then there are a lot of intermediaries in supply chain. There are distributors, there are, as I mentioned, group purchasing organizations, which we could say a good deal about. And the group purchasing organizations for many of the countries in the Middle East are actually located in Europe and the United States. And so those intermediaries tend to be global, and they tend to work with producers that are all over the globe, and that's very important. The range and criticality of products is also interesting. As I've already mentioned, a hospital may have 50,000 SKUs in their item master. Just think of a children's hospital, though, where patients come in many different sizes, and you just don't need 2 versions of a product. You may need 5 or 6 or more versions because you're dealing with individuals and their growth, which is very important. And the complexity, and increasingly healthcare products are very complex. When we think upstream about the factors that impact the healthcare supply chain, and we think of all of the monitors that are in patients' rooms, when we think of all of the IT that runs that, the crisis that we're having globally in semiconductors impacts the hospital significantly. So the hospital supply chain is not just about products that are uniquely medical products, but it's the competing for those products that other industries use. And, you know, from the physician's perspective, as I've alluded to, they have diverse roles in healthcare delivery. And one of the roles they have is in selecting products and working to be able to do that. And many physicians have strong relationships with suppliers, and they tend to be loyal in many instances to the physicians with whom they have relationships. And therefore, they don't want to leave one supplier for another, even when perhaps there's demonstration that another product may be lower cost and equal quality, which is important. And one of the problems that we have here is that physician relationships frequently trump what happens in terms of product selection. And so that relationship between the buyer and the seller, and by the way, the hospital stands in the middle of that because they want to keep physicians happy. And in many countries, physicians have a choice on what hospitals they can go to. And therefore, you want to be able to keep, if you're a supply chain person, you want high levels of satisfaction by the clinical people for supply chain, because they may have the threat of moving from one area or one hospital to another. And that's very important. So supply chain for some organizations also is an enhanced piece for competition. In the US, increasingly, what we're having is hospitals having to publicly show what their cost is for various kinds of surgeries. And so if you take a hip implant or a knee implant, what's the cost of that? Well, that's a surgery that has a very high level of supply chain cost, and that may affect that. And when patients look at that, whether it's, especially if they're paying out of their pocket, they may decide to go to a lower cost hospital, and therefore supply chain impacts the sticker price. Some of that may be offset by insurance companies. And one thing I will say is that insurance companies and government insurers generally have not looked at supplies in a methodical and disciplined way, because they don't want to get into the population thinking that government is practicing medicine. So generally what they will do is defer to the clinicians for what they can do. And that again puts supply chain at a disadvantage in terms of managing and doing what it can. So let me just talk a little bit about supply chain design. One has to make decisions, just as you do in other kinds of sectors. Where's the location and where you're going to put the facilities? Where you're going to put your, if you're a hospital system that may have more than one hospital, do you keep the supplies in a consolidated service center that serves all of your hospitals? Or do you keep inventory in each of the hospitals? How do you go about doing that? What transportation systems that you do? And how do you use intermediaries? And so many hospital systems, both in the US, in Europe, in the Middle East, use distributors. And so they've outsourced some of that warehousing and some of that inventory to distributors. And therefore, when you develop a relationship with a distributor, you also want to understand and you want to make sure the distributor understands the levels of risks that you're willing to take in terms of your managing your supply chain. But you also want to make sure that that distributor is looking out for your best interest, rather, because distributors make money by selling more products. And generally, they make more money because there's a markup for the distribution by having more expensive products. And therefore, you want to make sure that your distributors are in line with really what your strategic goals are. I won't go into the details of this. I'll let you do that yourself. But what you can see is this is a very complex supply chain. It has payers, people, the government, and others who pay for the insurance companies who pay for care. Some of it is self-care. You have insurers, which are part of those payers. The providers of care, all of those different, and those are influencers. Those are people who influence what products are there. And those are people in different settings, not just the hospital, but in physician clinics, post-acute care, nursing homes, and even within pharmacies. During the pandemic, for example, here in the States, many patients went to pharmacies to be able to get their shots for COVID-19, to be able to get their medications. And therefore, pharmacists were doing much more than they did before. But we also had to have supply within the healthcare supply chain, those pharmacies with products that they never had. Syringes, for example, which were very hard to get to because there was a huge global demand for syringes. And then there are, of course, the producers, the suppliers, and the distributors, which I've been talking about. And one of the issues is that in the past, these organizations fairly have not talked to each other. They've tended to be very fragmented. And therefore, when you think about the healthcare supply chain, one of the issues you have is the great deal of fragmentation and want to think about what are the things you can do to really make it more efficient to get those parties across that, the leadership across those to talk to each other and to take each other into account as they do their strategy and their management. So hospitals are, as I've suggested, this is sort of a summary. Physician preferences are high, physician preferences for specific products, but physicians are frequently very even unaware of what a product costs. When a physician reaches for a product, he doesn't ask the nurse, if I take product A versus B, which one is least expensive? Or even perhaps which one is more effective. So that's important. And by the way, the physician is often paid not just by the patient or the hospital, but perhaps by government. And so there's third-party reimbursement, and that's interesting. One of the areas where I think as you go through your careers, you want to be able to look at is how do we pay for supplies? Are supplies paid for at the end of a admission? Does a patient get a bill for every one of the supplies that's used? Or does it come in some other ways? And what I want to suggest to you that there are many different ways of paying that one might think of as important. I'm sorry, I just skipped ahead here too quickly. But there are many different models for reimbursement for supplies. And so increasingly in both the US and Europe and some countries in the Middle East, supplies aren't paid for directly. They're paid for as part of a bundle of a total admission. So when a patient goes into the hospital and a patient has an operation such as a hip replacement, the hospital may get a global payment. Let's just say $10,000 for that admission. And within that $10,000 are the doctor's salaries, the overhead to the hospital, and importantly, the supplies. And so supplies are an area where you don't basically turn over a bill to a insurance company or a bill to government and get paid for that discrete product, but as part of what I would think of as a bundled payment, or what I would think of as payment for an episode of care. How much are we going to pay for a patient who's admitted who may have preoperative costs, in-hospital costs, And then post-operative, including nursing home or rehabilitation center, and of course, the cost of home health care. And so in different countries, we see very different schemes for how we pay. Some we pay fee for service, some we pay for bundles in terms of what that looks like. And so one of the questions that I think as a supply chain manager within the healthcare environment, you need to understand how reimbursement happens. And you also need to think about, if you're being paid for a bundle, what are the incentives? And so you may have a physician, a surgeon, who for every operation that she does or he does uses some kind of bone graft accelerator. But there may be data that that bone graft accelerator that costs $300 when you put it in, it has no more effect than a patient who's had surgery without it. And so having to look and understand the comparative effectiveness of different products is very important. And let me just say that we have very little comparative effectiveness research when it comes to devices, medical devices, such as implants. So we really don't have great data to show you that, for example, the Stryker hip is any better than the Johnson & Johnson hip or a hip that comes from another company. And therefore, without that comparative effectiveness research, it's difficult to convince a clinician that product A is equivalent or the same as product B, given what their own personal experience may be within that. And by the way, think about this for yourself. You never want to have a physician use a product that he or she doesn't like or a product that he or she is uncomfortable with. But having the ability to have some comparative data on that, and one of the roles of supply chain is to work closely with clinicians. It's a skill that you must develop if you're going to work in the healthcare industry, to be able to work with them to understand how their preferences guide their decision making and how you can provide data to them to help implement that decision making. And that's important. The last point in this slide, absence of price transparency, is important because frequently what suppliers have hospitals do is sign non-disclosure agreements and within their contracts. And that means when a hospital A within your community talks to hospital B and they've signed a non-disclosure agreement, they can't say, what do you pay for that? Because that would, in a sense, break the contract. And therefore, there's not much transparency and therefore not the ability to comparatively test pricing, not just only to comparatively test the effectiveness of a given product. So we have new models of reimbursement, episode of care, a lot of new technology coming in, particularly with high-priced implants, such as in spine and orthopedics, and an absence of price transparency. That's very, very important, okay? So I've mentioned these all, GPOs, group purchasing organizations, organizations that help you aggregate purchasing volume, traditional distributors that hold products, and then new actors. And so here in the US, Amazon is a major distributor of healthcare products. DHL, Federal Express, all of those companies are very important and are going into healthcare in very big ways. So they become part of that whole both distribution model in very significant ways. So this shows you sort of the typical flow of products going from a manufacturer, supplier's warehouse, to a bulk store within a hospital, to a working store, to an operating theater, and increasingly to the patient's home, because many products that were traditionally used just in the hospital during COVID, for example, got used in the home more often. And the hospital supply chain is a little different than the pharmaceutical supply chain. And it's very complex. Just look at all the different nodes here. I have my students try to do research on each of these different nodes and understand where cost is. And by the way, every time there is a node or an intermediary, that basically impacts in very significant ways what is happening in terms of cost, because every one of the people at that nodes, whether they're doing finished products or raw materials or packaging, want to be paid. So one can continually add some percentage to the end cost of that supply chain before it gets to the hospital who's paying the bill, or the patient who's paying directly, or whose insurance is paying for that, or if the government's paying for that. And that's very important. And what we have seen is that the costs of distribution, and you've seen it over the last year, you're seeing it now, the cost of those distributions, whether it's land or sea, is very expensive and continues to escalate, which is important. So there are a number of ways of paying. This is just a slide for you to look at on your own. But you have fee for service, and we want value. And so what we want when we have value, we want accountability of the providers. We want to be careful not to have higher administrative costs and more, you have more expenditure for care. When you go to value-based care, you're suddenly concerned with the value you get for the product. You're much more concerned in value-based care for the outcomes in terms of what that looks like. And you're really much more concerned with the coordination, that a patient doesn't stay within the nursing home too long, doesn't stay within the hospital an excessive number of days. And yes, over time, we've seen the average length of stay go down very significantly, but that's important to note. So payment comes in many different ways. I took a look at Egypt, and there are 6 different healthcare provision insurances within Egypt: fee for service, payment out of pocket, population-based payment, the kind of bundles I've talked about, and also patient-centered payment, evidence-based care. Let me stop there. I've been talking, and we have many other slides, but I just want to see what questions you have up to this point.
First
Please
of all,
speak up.
Thank you, Prof. Schneller, for this. For me personally, it's helped me to know more about the healthcare system, as I already work about a system, healthcare supply chain. So we know that the healthcare supply chain has an advantage and enhance supply chain to make doctors to maybe valuable in its core business, or it's maybe a surgery or something like that, so they can make everything at time, from supply relation to have medicine in its time, the surgeon is ready to work in it or something like that. So all of that, it's help in the end to the patient. So supply chain healthcare is very important topic for everyone. So now we can start to take a questions. So if anyone had a question, please go ahead.
So no questions?
Rana, Mariam, Ahmed, anyone has a question?
Okay, how much more time do we have? Because I can keep going here.
We have maybe 20 minutes. So
okay, well, let me just go a little further, and then I want to leave some time for more discussion, okay?
Maybe they want to prepare questions, or maybe they more thinking about it till we can go.
Think about some questions for the end, because,
Okay, yeah.
Okay, well, let's move forward, okay? So, one of the things that I've been talking about is where the costs are for supply chain. And what you see is within this slide is that a lot of that cost is in the hospital, but others are in readmissions. And so one of the reasons you want a great quality product is that you don't want it to fail. When a physician when a product fails, such as a hip or a knee or a pacemaker, they have to do what's called revision surgery. And revision surgery is very expensive. So it makes you want to choose high quality products so you don't pay twice for the same thing. You certainly don't want to have to do that, right? That's not desirable. Think about your management class. I put this in here because what I've been describing to you, and if you see this graph, is a very uneven, on the left side, you see a terrain that has lots of peaks in it. Those are all the different points where supply chain comes into it, from manufacturing all the way to the patient. And one of the goals, as you think about yourself as a designer of a healthcare supply chain, is how do you smooth that out? How do you develop a smooth terrain so you reduce the number of times a product is touched? So you reduce the number of times that that product has to be moved from point A to point B from a distribution perspective. And so you want an efficient supply chain, and you also want one that's responsive. And by the way, responsiveness and efficiency are two different things. Okay, responsiveness may mean that you keep lots of inventory just in case you have a stock out. By the way, one of the major causes of supply disruptions are fires within manufacturing plants. And so if you've single sourced and that manufacturing plant goes down, you no longer have that supply. And so do you want to smooth it out so you have only one supplier, or do you want 2 or 3 suppliers for the same kind of product to reduce the amount of risk that exists within your supply chain and your organization? So when I go out and I work with hospitals, I tend to think of the idea of what I call a fully integrated supply chain organization. And my textbook on healthcare supply chain strategy is built around these 3 areas: the supply chain processes, the technologies and the tools, and then the organization support that needs to come out within that. And so within the processes, you have, and by the way, if you've studied supply chain in other industries, many of these are the same. You have to source products, selection, and standardization. We've already said physicians get into that in a very big way. Just imagine if you were building Ford motor cars and every engineer liked a different tire manufacturer. One of the engineers liked Firestone, another liked Pirelli, another liked General Tire. They'd be fighting all the time over what the best product is. And you can't have that in most industries. But here in healthcare, we need to figure out how we work with physician preference to have that best product. And by the way, I'm not trying to convince you that the clinicians are your enemy if you're a supply chain manager, but they are the people with whom you need to work with to achieve the goals of the organization, to have great patient care, to be able to do that. And of course, you have a variety of technology tools, increasingly the electronic health record. Now we find we've got electronic health records, but they don't talk to the supply chain management system. So we get into this issue of interoperability, that we need IT systems to be able to have effective supply chain that are able to talk to each other. And what we lay out in our research, and happy to talk to you more about it or provide other material, and you see it in our book, is the technology tools that really facilitate that happening in a very good way. And this is just the simple process of procurement, okay? These are all the different things that go into procurement, sourcing and purchasing, all of the things that need to be happen to be able to do that. So supplier manager, contract management, requirements, those are all the things that go into that. And then you get into the actual purchasing of sending out a requisition and approval and costs, etc. And that's really important to think about. And again, this is just another schematic. Again, I won't walk you through it, of category management, general procurement, etc. Okay. Since we don't have a lot of time left, I want to jump forward to this last section. And this section really talks about what happened during COVID. And some think that COVID was really an unusual experience, but we have had other issues before, and we will have those issues again, such as stockouts. I'm sorry, I'm not doing this very efficiently, am I? So we've become very concerned with resilience. and not just building cost, quality, and outcomes, but building a resilient supply chain. And one of the roles of supply chain in healthcare has to be one that's proactive, to be able to, in a sense, anticipate what might happen. Therefore, in terms of your supply and your supply base, to do that. The ability to be reactive, to be able to deal with the damages that may happen. And finally, to transform the supply chain to make it a better place. And so I talk about cost, quality, outcomes, plus resilience. But if we go back, let me just go back a couple of slides here, if you'll permit me. I'm sorry, this is going very slow. So here we go. The problem that we had during COVID was that it was a perfect storm, is that government had promised to reduce risk by holding stores, and that really didn't happen. Government did not have, at least in the United States and most of Europe, was underfunded, did not keep large stores of protective equipment, and really hadn't looked at risk in any systematic way. And in a sense, we had spent so much time with the, in your supply chain courses, you learn about just-in-time inventory, you learn about lean, but those concepts led us to look for the lowest prices and to keep very low inventories. And during COVID, there were three major unknowns that I want you to think about. We didn't know how long it would last. Okay, little time to respond. We didn't know how long it would go. We didn't know its depth, how deep it would go into the population. Would it just affect women or men? Would it just affect children? We didn't know about its depth. We didn't know about its width, how much time to respond. And we really didn't know when it would stop. And there are times it went up, and then we had a new version of COVID. And supply chain had to constantly respond to that. Supply chain had to constantly be able to work around that to be able to move forward, which was really very, very important. So let me end my slides here, which you can have, and see if you have some questions. I hope I've raised some issues that are really interesting and hopefully important.
Okay, I can start asking first. So what do you think about the future of the healthcare supply chain hospitality system, as maybe AI and blockchain integrated with it?
Yeah, so both AI and blockchain are finding their way deeply into healthcare, particularly into chains of custody. So think of pharmaceutical products moving through the supply chain. And so they're very important to be able to do. AI is helping in doing projections, but we also need to understand that AI is also a suggestion of the right thing to do, not always talking. It doesn't take into account, how does one take into account physician preference in AI when you're working with very different doctors? And so if you go in and you say to AI in ChatGPT, give me the best purchasing strategy for a large hospital. Well, the questions I've raised, do those physicians work for the hospital? Are they paid? Are they employees? Should we have the hypothesis that if a physician is employed, they're more likely to do what you want them to do as a supply chain manager? The answer is probably not. Okay. And so blockchain can help, it can help you find some best practices, but will it take into account the culture of the organization and the culture of the environment in which you're dealing? And culture is really very important in consideration. Will it become much better at that? Yes, I believe so. I have a good friend who's a radiologist. He does mostly radiology for breast cancer, and they use AI. And he says, in 98% of the time, AI gets the right diagnosis, but in 2% it doesn't. What's the right rate of using AI to be able to do that. And, we need to be able to understand how we deal with what those limitations are.
Okay, thanks, sir, for this answering. It's appear more about this question, yeah. Other question, maybe from student? Okay, Mariam, go ahead.
Okay. My question was that how can the supply chain of hospital cope with unexpected events like emergency or natural disaster?
Well, what we've seen is the short answer is not very well. Okay. One of it goes back to my slide on resilience. How much stockpiles should we have to prepare for those three uncertainties that we looked at in the last one? So in 2 states in the United States, and we are a very big country, there's a mandated 90 days of inventory for physician preference items. Okay, which 90 days? The 90 days when a large hospital was using a tractor trailer load of PPI, the average day? Those are very difficult questions. And how do you manage those things to be able to have that level of preparedness? So one is to look at the whole issue of stockpiles. We have several strategies, at least in our country we're doing. One is we're trying to bring more manufacturing into the United States. It's very difficult to do because many of those raw materials are in Asia. Many of them are in China. The active pharmaceutical ingredients tend to be outside the United States. Some of them pollute. So think of examination gloves. That was a big problem during COVID. We can begin to manufacture those, but guess what? It pollutes terribly to have to produce manufacturing gloves, surgical gloves. And so one has to think of what's the environmental impact of reshoring things that unfortunately we've left in other countries where the laws regarding pollution aren't as strong. I mean, you've seen that with that discussion was obviously just in Dubai at the discussion of what environmental. Look, in almost every community, the hospital can be the largest polluter. Just think of all the plastic. Just think of the human waste. Just think of all of the things that come out. So sustainability is something that needs to be top of mind. To what extent is sustainability stand in the way, for example, of having the problems of having larger stockpiles or reducing risk by bringing manufacturing closer to you? And will manufacturers really want to go to small countries where quality is an issue and those are issues? Thank you. Good question.
Okay, thank you.
Thanks, sir. Ahmed has a question. Go ahead, Ahmed.
I'm here.
Ahmed, I can only see the top of your head, so move your screen down. I want to see. There you are. Okay.
My question is, what is the 4 major categories for supply chain healthcare?
I'm sorry, could you just say that a little closer to your screen? I had trouble hearing to your thing.
What are the 4 major categories for supply chain operation for healthcare?
What are the 4 measures?
Yeah.
Well, as I've already suggested, one is cost, the cost of goods. Okay. And one can look at cost of goods in many different ways in terms of metrics. One can look at total cost of ownership. And so if you're looking at a medical device, how long is it? What's its half-life? How long is technology going to, a new technology going to come about and basically replace that? And obviously the cost is also another aspect of cost is if you change to another product, you have to go retrain people. Okay, and so that's one of the problems. So cost is, all of the dimensions of cost are very, very important. Quality is a second very important kind of consideration. And just think, I've talked a good deal about implants. There are implants that are made to last many, many years. And there are implants that are made, for example, for elderly people. Do you put a implant that's very expensive into somebody who's 80 years old? And by the way, do I want them to put that implant in me, or an implant for a younger person that may be a more durable and longer lasting implant? So it's not just the cost of it, but it's the quality and the impact that needs to, we have metrics that we have around cost, but we also have impact. We also have metrics around quality and what those are. And we want to link those to patient outcome and satisfaction. And satisfaction is a softer measure sometimes. It has to do with the ease of use of something on the part of a clinician or a patient, which is really interesting. And then, of course, resiliency. But, happy to supply, there are many different metrics that a hospital uses in terms of measuring inventory, days on hand, numbers of turns. Many of those are the same inventory measures that you would see in almost any commercial organization. But then you get into those that are much more clinically focused.
Thank you.
Okay, Ibrahim has the next.
Hello,
Go
good
ahead.
evening, doctor. I have a question, please.
Please.
How could the supply chain of the hospitals how could the supply chain of healthcare is useful for the hospitals if there is an urgent surgery and they want some medical supplies from the supplier? In how many hours could you get the supplies available for them?
It's a very difficult question. Okay, first, I think it depends where you are in the world and how close you are to where stores are. Here in the United States, a huge number of supplies are available the next day, particularly if they're critical supplies. Sometimes when there's a disaster, those supplies are problematic. Just think of blood, because blood has a short shelf life. And so you have a disaster and you need lots of blood and you can't keep that much around, right? And so you need to share. So one of the areas we've been very interested in, given since the pandemic, is the ability of organizations within a community or within a region to collaborate. So one of the big shortages that we had early in COVID was for ventilators. Ventilators are what you put a patient on who needed help in breathing. The first part of the pandemic was in New York, and New York used lots of ventilators. But then on the West Coast in Seattle, we had a huge breakout of COVID, and we were able to move those to very quickly, actually, to another place. So one of the kinds of organizations that get supported are stockpiles, and government usually does stockpiles, but I'm increasingly believing that communities may want their own stockpiles. But how do you finance it? And so resilience is not cheap. When you have a stockpile, you need to manage it. You need to rotate the materials. You just can't put it in the door and shut the door. And then for what? Is it going to be another respiratory disease like COVID? Or is it going to be something that's more severe? Say, if it was an outbreak of a hemorrhagical disease, like, something that was really very different. And so you can't plan for every kind of disruption that would, that would happen. And so one of the things is to get together within communities and create those so that each individual organization is not incurring that. But if you're in an environment where healthcare organizations do not want to share as we are in many instances here. During COVID, people shared the number of masks they had. They shared their inventory levels. And now that that's over, that transparency is going away. Many of them do not want to share in the same way.
Okay, thank you.
You know, here we had a Ebola scare, and every hospital in the United States wanted Ebola suits. And, you know, we had very few, you know, how many, given the fact that Ebola may be very rare, although it could happen, given that it doesn't spread in large areas easily, but it could happen. How do you deal with that? How do you prepare for that? It's very, very difficult. And so you want to be able to buffer yourself, and you want to be able to use distributors who will act in your best interest to be able to do that.
I think Ron has a question.
I wanted to know what technologies or systems do you utilize to optimize the procurement and distribution processes?
Sure, good question. So most hospitals have a materials management software. And that materials management software can keep track of utilization. In many instances, hospitals purchase cabinetries. And those cabinets, you've probably been in a hotel. If you take the bottle of Coke out, it tells it's been used, okay? But those cabinets are expensive, and you can't put thousands of things into them, but you can put things in those. And so you basically have smart cabinetry, Raina, that you can use. It's used frequently for pharmaceuticals. So every time a nurse goes in to take a pill out for a patient, he or she uses a barcode to open it and take something out. And therefore, you're getting signals down to procurement that's saying, hey, they're low, come and redo that. Many hospitals use Kanban systems. You know what Kanban systems are? Those are, you know, basically you have two bins and one bin in front of the other. And so you have inventory in both bins. And when one bin's absent, you put the bin down and it has the SKU number with a barcode. And therefore, somebody comes around to all of the different floors on the hospital and picks up those empty bins and goes and replenishes those. That's a little more manual, okay, because somebody has to go do it. But the cabinetry should be used for only sort of high-priced, high-risk things that you need. I was in a hospital and somebody was complaining that all of the resident men were putting their shaving cream into the cabinet, and you should have, you know, that cost, you know, very little money, the travel size ones, because they cost too much money to buy. And so somebody was putting those in, and you should have high-priced drugs in that and high-priced devices. Increasingly, AI is being used. It could be used in a patient's room, so that when you see somebody take something out of that room, AI would detect that that went out. But that's, I still think that's a little futuristic and is not going to be there as much. But certainly one can have a smart room where everything that goes in and out gets measured in that kind of way, where a camera can translate that. And I think that's important. In many instances, hospitals here have vendor managed inventory. So just think that there are many sutures, all the sutures that you use to sew up patients, and they have different kinds of needles and different lengths of thread. And if you go into a big hospital, they'll have a whole wall with many different sutures. And sometimes the vendor will come in and manage that. Okay, so it's vendor managed inventory rather than inventory managed by the hospital itself. One of the problems is that in the electronic health record, in most electronic health records, they're not linked to the supply chain materials management system. And so one would love to, and that is changing. The other big problem, Raina, and you've raised it, it's important, is that the use of UDI, unique device identification. You could do a paper on unique device identification. One of my students in Kuwait and I have written about this. And unique device identification, when you go to the grocery store, you pick up something and they scan it when you go out of the supermarket. That has a unique device on it, and frequently that will go right back to Procter and Gamble or whoever the manufacturer are. And when you get enough of those, they say replenish that stock. Hospitals have not, the healthcare has not had in general a unique device identification. The company you want to look at is called GS1, Global Standards 1. Most barcodes are on GS1. GS1 has now gone deeply into healthcare. But frequently a hospital will come in, a product will come in, and they'll cover up the GS1 universal code with their own code. And therefore, you basically have several reporting systems that make it much more complex to be able to do. So there are a lot of technologies. We've spent time looking at our large defense system, Department of Defense. Much of what they had were just on spreadsheets, and they weren't even using barcoding. And so you would think that someplace as advanced as the U.S. Department of Defense would have advanced barcoding, but in many instances they don't.
Thank you. Thank you so much.
Yeah. Yeah, and also think that healthcare tends to be a late adopter. It tends to follow other industries, and we've done some papers on the rate of adoption of that. And you tend to see that in supply chain.
Yes, we do. Thank you so much.
You're welcome.
I think we can go to the next question with Bismillah.
Why is supply chain and logistics important for healthcare and hospital?
Could you say that again and get a little closer to your speaker? It's hard to hear you.
Why is supply chain and logistics important for healthcare and hospital?
What was the last word on?
She said why supply chain is important for supply chain and logistics, and
No, why is supply chain and logistics important for healthcare and hospital?
okay. She asked why supply chain and logistics is important for healthcare and hospital. Yeah.
Well, if the product's not there, nothing happens. I mean, you know, it's the 21st century doctor needs supplies. Nothing makes a doctor more unhappy than when they reach in the drawer for something that's supposed to be there and it's not there. And the standardization that I talked about is really important for many reasons. I was talking to an orthopedic surgeon, and there are many different, let me give you an example. There are many different suppliers for hips, a hip implant, and which is very big among older populations. And if we don't know what's in there, the doctor opens you up and he or she may not have the right instrumentation to be able to fix what's there on a revision surgery. And that's really important, because if you're on the tape, and by the way, we have done until recently very little entry of the serial numbers of an implant into the electronic health record. So many years ago, one of my kids, one of my sons, who is fine now, needed scoliosis surgery. And that's a very big surgery in the back. It has to do with curvature of the spine. And they put a rod in the back. They put many screws in, many different parts. And I asked the doctor if I could get the serial number of every one of those parts. And he said, well, why would you want that? And I said, well, what if he's in a car accident? He skis. What if he's in a skiing accident and he gets to the hospital and the doctor wants to know what's in there, what he's going to find? If he has to replace it, does he have the right screwdriver to unscrew the screws? Because there are many different kinds of instruments, and every supplier has different instruments. So supply, and by the way, he said, nobody ever asked me for those before. And I said, I'm a supply chain guy. I'm a pain in the neck. But I said, I'd like him to have that because, when he grows up, he may need that someday. So supply chain is important. How it's managed, how it's recorded is important to the patient. And I wanted to know that that doctor was putting in the best product for that kid. Okay. And that was going on. So I think there's an emotional side to supply chain that we don't feel very, when you walk into I'm sure you've all been in an emergency room at some point, whether it's for yourself or for your family, and you look around and you see how intensive the supplies are. How did that get there? What would they do? How would they stop that bleeding? What if they didn't have the sutures? What if they didn't have the blood supply, which we have not talked about, is a huge issue. And how do blood banks work? What's the supply chain for a blood bank for replenishing and being able to do that, given the different types of blood? During COVID, very interesting. People didn't want to go out and donate blood. Okay. Well, in some ways you didn't need as much because there weren't as many big surgeries being done. And on the other hand, people still got into accidents. People still needed those blood products. And so the blood, the supply chain for something like blood, is in you. It's in your house. It's in your family. If you don't do it, there's no blood. If you don't have the blood, you can't do surgery. Hurricane Maria happened in Puerto Rico several years ago. Puerto Rico is an island in the Bahamas. It wiped out the only plant that was making blood bags, the bags they put blood in, and that they put IV solutions in for servicing the United States. Suddenly you could collect blood, but you didn't have any bags to put it in. Suddenly you could have sterile injectables, but there was no bag. And by the way, can you move from one to the other? Well, one company may make blood bags and the connector, think of the connectors, the tubes that go down into that. The connectors aren't standardized. So the Johnson & Johnson connectors are different than the BD connectors. And so you just can't take one and put it in the other, just as you can't take the hood off of a Ford and put it in a Chevrolet. We have very little standardization within healthcare, and we need to move to more. And one of the reasons, to go back to the other question, of having backup is, you have backup if you can't agree on the product and its configuration and its standardization. It's very difficult to have stores where there's no standardization by all of the end users. They all have to be happy with what those look like. Okay.
I think that I can take the last question before we end. First of all, as you said, and I know that the supply chain has had two ways to be cost efficient or responsiveness, and this is a trade-off between them. So what is the best suitable for hospital system, as it must be, I think that must be response to the customer quickly or the patient quickly?
So I don't have it here, but just think of a graph with efficiency on one side and a responsiveness across the y-axis, efficiency. And just think of the different points between efficiency. So you've got basically an X and a Y-axis, efficiency up on top, high levels, and on the other axis, high levels of responsiveness. New York mandated 90 days of responsiveness for PPI. So you've got, in other words, they've said you've got to be highly responsive and keep 90 days of inventory. We can't afford to do that with everything. Number one. Number two, the margins of a hospital, the profitability of a hospital in the United States is actually very low. 3 or 4% is the margin. You probably would not build any other business with a 3 or 4% margin. Okay. There are some profits that have much higher margins, but the average not-for-profit hospital here is about 3 or 4%. And so responsiveness is expensive. And what we're seeing post-pandemic is going back to a focus on cost rather than resilience, cost rather than responsiveness. And we're saying that was a black swan affair. In the slides, you have a picture of a black swan. It happens infrequently. But, you know, could we have an Ebola outbreak quickly? How many Ebola suits should a population, you know, of 50 million have? What's the population of Egypt? I don't know. I'm sorry. But, you know, should every hospital have enough populations for everybody in Alexandria?
More than 100 million.
So it's a very difficult question. And
Yeah.
I think that that fuels the search for efficiency and lean and just in time. But what we learned is that you need to buffer efficiency and lean and just in time with the ability to be responsiveness to a population. Now, we do it pretty well because in Florida, which is a state in the United States, we know we have hurricanes. And we have very big stores in Florida because hurricanes happen every year. So it's easier to anticipate that, something that goes out every year. We know in parts of the United States, we have forest fires. They happen every year. We anticipate those, but they tend to be short. They tend to be predictable, and we can understand what recovery is, okay? Now, a hospital has a different problem. What if you have 5 sets of triplets all at once? And they're all premature. So now you need 15, basically, incubators within the neonatal ICU. That's pretty unusual to have 3 sets of, you know, 5 sets of triplets all at once. What's the probability of that? Probably close to 0. And so we do have companies that we call peak use companies, and they rent out equipment to people when something like that happens. They keep things for the unexpected, but they can't keep that much because they basically have inventory that's never used. But I'll leave you with a thought, and maybe you have a comment on it. To me, the best supply chain are fire departments. I live in Phoenix, big area around me, many different counties, many different fire departments. They all have the same hoses. They have all the same hookups. They have a common storeroom for the products because they go to emergencies, and we pay for them. I never get a bill for the fire department. It's part of my taxes. It's built in. Do you get a bill for your fire department? My guess is you don't. You either pay for that through your taxes or government's paying for that, but you pay for government through your taxes, right? And so we've decided that it's worth protecting ourselves from fires. And I know that the fire department, and by the way, most of the time, those firemen and firewomen, we have more women in it today, which is great, but those firemen and firewomen sit around most of the time. They polish the fire engine. They make sure it starts. They wash it, and they drink beer and make dinner. That's what they're doing most of the time. But when there's a fire, they're there. We're paying for standby, right? Can we do that for healthcare? Well, we can do it for some of it. Can we do it for all of it? I don't think so. Raina, what do you think? I'm watching you.
I think that
I personally think healthcare is very unexpected. Obviously, like the COVID, but when it comes to firefighters or the fire station, it's obviously way more expected, and they're way more ready than when healthcare would be.
Exactly. And so it's, if we could do that with everything, we'd be happy. We wouldn't have that problem. But unfortunately, it's an expensive standby that, it's basically one of those services that's standby. And we only use it when we have to.
Exactly.
Well, thank you for this opportunity. It's been great to do that. I'm sorry I had so many slides. I tend to go too fast, but I hope that that made sense. You can get our textbook on the web if you're interested in the strategic management of the healthcare supply chain. Much of this is in that. I have not traveled lately. As I mentioned, we did some work in King Faisal in those hospitals, which are What's actually interesting, and I'll leave you with this, when we went into the storerooms in Saudi for the distributors, the name of the hospital was on the product. And they weren't allowed to move the product from hospital A to hospital B. So it meant that King Faisal had bought that, but I don't know, whatever the British hospital in Saudi Arabia bought it, their name was on it. So it wasn't a stockpile, it was really a place of storing your own inventory to be able to do that. I don't know if during COVID they relaxed that and let people share, but part of it is that at the end of the day, in many instances, healthcare is a business. You have a mix of different public and private ones. My guess is you would not have private hospitals in Egypt if they weren't making money. They wouldn't go there. They wouldn't make that investment, right? And so that mix makes it even, I think, many more challenging. And countries with socialized medicine, like the United Kingdom, are increasingly public-private. There's a lot of private insurance within the UK. And so the problem is not easy to solve for either, because you want that preparedness.
Thanks, Prof. Schneller, for your time and for this presentation. As I think that's all for today. Hope to meet you soon in another seminars and speak to you, or maybe physical meeting. Thanks for all audience, and have a good day.
By the way, we're also looking for great graduate students. So if you are looking for a master's degree or something else, think about Arizona State. I can't let this go without recruiting.
Yeah, sure. Okay. We can speak about this point and maybe email or something like that. We can make see how can we make exchange programs or something like that.
Well, I'd be happy to talk about that. We're always interested. We do work all over the world, and be happy. You just go on our website and you can see it.
Yeah, we are happy to see so. Okay.
If you could send me perhaps the emails of your class, I would like that. I can follow up with them on some things.
Okay.
If they'll agree to that.
Okay, sure. After we finish, I will send it.
Okay. Thank you. Enjoy.
Thank you.
Have a good day.
Bye-bye.
Thank you, everyone.